Welcome to today's HealthLine webinar from the American Association of Kidney Patients, titled Non-Surgical Vascular Access Creation for Hemodialysis, an AAKP HealthLine Innovator webinar sponsored by BD. My name is Erin, and I am AAKP's Director of Patient Insights, Data Analytics, and Advocacy. I oversee our patient research and education activities, as well as our grassroots engagement activities, including our Ambassador Initiative, which falls under our Center for Patient Engagement and Advocacy. And we will be hearing from one of our ambassadors later on in the presentation. AAKP's HealthLine webinars fall under our Center for Patient Research and Education. We believe patient and caregiver education is an integral part of treatment and protection of patient lives, and we work to ensure that the patient has a central role in research and guidance that are designed to determine optimal approaches and strategies for providing healthcare services, assistance programs, and access to new products and services. We built this center with the latest polling and engagement technologies to ensure that kidney patients take a central role in informing the federal, academic, and private sector research, shaping the next generation of healthcare services, assistance programs, and innovative new treatments. And we encourage you to respond to our flash surveys and other engagement opportunities that you receive via email. AAKP is pleased to launch our Innovator webinar series, an extension of our normal HealthLine webinar programming. The content of this program, as presented, and financial support of this webinar was provided by BD. As the oldest and largest patient-led kidney patient organization in the U.S., AAKP is proud to host this Innovator webinar as a service to the expanding national and global communities of patient consumers and their families, medical practitioners, researchers, and policymakers following innovation and advancements in kidney care and treatment. AAKP is an aggressive supporter of innovation to change status quo care. While this activity is an approved educational webinar, AAKP does not endorse this webinar, nor endorse or promote any specific commercial entities or products. And thank you again, BD, for sponsoring this. With that, let's get started. We have a great program today, and I'd like to introduce the moderator for today's webinar. Dr. Prabir Roy-Chaudhury is a professor of medicine and co-director of the University of North Carolina Kidney Center. After graduating from the Armed Forces Medical College in India, he trained in internal medicine and nephrology at the University of Aberdeen, Scotland, and at the Beth Israel Hospital, Harvard Medical School in Boston. In addition to being an active transplant nephrologist, Dr. Roy-Chaudhury, his main research interest is in uremic vascular biology, including both dialysis vascular access dysfunction and cardiovascular complications in kidney disease patients. Dr. Roy-Chaudhury has been the recipient of extensive NIH and VA research grant funding, has received national and international awards, has published over 190 papers, and is a sought-after invited speaker both nationally and internationally. He has also been actively involved in the public policy and administrative aspects of dialysis vascular access care and hemodialysis. And he was the founding American Society of Nephrology co-chair of the Kidney Health Initiative. He is also a counselor for the American Society of Nephrology and a member of the steering committee of the Kidney X Innovation Accelerator, which is a public-private partnership between HHS and ASN. Dr. Roy-Chaudhury, we're so pleased to have you join us today, and I turn things over to you to get our webinar started.
Great, wonderful, Erin, and thank you for that very, very kind introduction. First of all, I really want to welcome everybody in the audience. Thank you for joining this webinar. And I particularly want to thank BD and the American Association of Kidney Patients for both sponsoring and hosting this particular webinar. I want to say right at the outset that I am really excited about this webinar. And the reason that I am excited is that we have, I know on this webinar, a large number of people living with kidney disease. We have to think about, and I've avoided the term patients. I think we are partners together, and all of you, or many of you, would be people living with kidney disease. And the reason that it is so important to have so many of you on this call is that we often forget that the most important person in the vascular access community is not the surgeon, is not the nephrologist. I'm sorry, Neghae, and I'm sorry, I'm a nephrologist as well. And it's not the dialysis nurse, but it's actually the patient. And I say this because the best vascular access care occurs when patients or people living with kidney disease are both invested and vested in their vascular access care. And I think that this is particularly important as we look towards the future, as we look towards innovative options for vascular access, because I think that if we want to move the needle for vascular access, we have to work together as a community with patients at the center of this community, because it is through our patients, through people living with kidney disease, that we can really spread the word about innovation and new ways of taking care of patients who have vascular access issues. And I really think that people living with kidney disease have to be at the forefront of spreading the word about innovation in vascular access, and very, very importantly, with regard to advocating for innovation in both the kidney disease area and in the context of vascular access. Finally, I want to say that the American Association of Kidney Patients, led by Richard Knight and my very good friend Paul Conway, I think has been a powerful, powerful force for moving the needle, a powerful, powerful force for good in the vascular access area. So again, Erin, please, I thank you so much for AAKP in many ways leading this fight against both kidney disease and trying to make things better for patients with vascular access problems. I think that a good way to start this session, which is really focused on patients, on people living with kidney disease, is to start with a video about one of our panelists, from one of our panelists, Christine Hernandez, who I will introduce in a moment.
I started doing research on fistulas and which fistulas are better, which ones are safer. Was there a minimally invasive fistula? If it existed, I came across a study talking about this procedure called WavelinQ. I said, hey, doctor, do you think we could look into this? This is something that I want. During my next appointment, which was a few weeks later, he told me, he says, Christine, we had a symposium and in-service on this procedure that you brought me. We're going to be doing it here, and I know the doctor that's best for this.
At this point, I'm going to introduce the second most important group of people for today's webinar, and that is our panel. And I hope you can see all of them on the screen. But I'd like to start off by introducing Dr. Neghae Mawla. Dr. Mawla is a nephrologist with Dallas Nephrology Associates. He is the director of the Endovascular AVF program and also the medical director of the Dallas Nephrology Associates Vascular Access Center in Plano, Texas. Neghae's passion, I would say, has always been about vascular access. I know that he gets excited when he talks about innovations in vascular access, such as endovascular creation and other novel and better ways of doing vascular access. And I do want to say, Neghae, that you have truly been a pioneer and a leader with regard to vascular access innovation. So thank you for being on this panel. Our next two panelists are really, I think, the reason why we are having this session. You've already heard from Christine. I want Christine to say hello, wave to the audience. Christine, if you're good, thank you. Thank you so much. So Christine is a mother, Christine is a registered nurse, but most importantly, Christine is a person who is living with kidney disease. She hails from the Chicagoland area. She's been on hemodialysis for over 2 years in both the home and the in-center environments. And most importantly, Christine has an EndoAVF. She is going to speak at different times during this webinar about her own personal thoughts about having an EndoAVF. And of course, she has been a wonderful, wonderful field ambassador, both for AAKP and for NKF, working to ensure exactly what I feel this webinar is all about, that the voices of kidney patients and their families are heard. So thank you very much, Christine, for everything that you have done and that you will be doing in the future. And then our last panelist is Brandy Taylor. Brandy, wave your hand to say hello to the audience. Thank you. And Brandy is a clinical laboratory technician, but in recent years, she has really been the provider for her husband who is on dialysis. Her husband has an EndoAVF. Brandy is his home hemodialysis caregiver, and in September of 2019, so 2.5 years ago, Brandy's husband received a WavelinQ fistula, and Brandy, over that time or since that time, you have really been the person who has been cannulating your husband's fistula, and Brandy is going to give her own personal experience during this webinar about what it means to be both a care provider for somebody on hemodialysis, but also the cannulator for her husband. So and Neghae, you're of course a leader in this area, but I'm going to put a bigger shout out to Christine and Brandy, because I think both of you really are in the center of this new push towards innovation in vascular access. So thank you to the—
completely agree.
What's that? You totally agreed again. Thank you. All right, I appreciate. So with that, again, thanks to all three of you. I think I couldn't have asked for a better panel. And with that, let's go, Erin, into the slide sets that we have. And just to some additional housekeeping points, so we're going to have some initial presentations from myself and from the other three panelists. It's really just to set the stage for what I hope will truly be an interactive question answer session. We have some questions that many of you on the panel have put in already. We'll start off with answering those questions, but as Erin said, you can put your questions in and we would be absolutely delighted to answer them. I'm going to speak a little bit about where we are at the current time with regard to both vascular access and your traditional surgically created arteriovenous fistula. And I think that one of the really important things that have happened within the last couple of years is that I think as a vascular access community, I really do feel, and when I say vascular access community, that is patients and dialysis nurses and technicians and nephrologists and surgeons and dialysis providers and interventionalists. We're all part of the vascular access community, but I think all of us really feel that the key thing about vascular access is to individualize vascular access care. So we've tried to move away from this one-size-fits-all fistula first paradigm. Many positives in a fistula, no question at all. But our larger goal, I think, has to be that we want to place the right access in the right patient at the right time for the right reasons. And I would argue very strongly that the endovascular AVF that you're going to hear about has a very important place within this paradigm of individualizing vascular access care. So what is an arteriovenous fistula? And again, I think many of you in the audience would be familiar with this, but it really is a connection between an artery and a superficial vein, either in the forearm or in the arm. And when you connect an artery to a vein, you get this high pressure, high flow from the artery going into the vein. And in an ideal situation, the vein, which is superficial, will dilate, and you will get a big dilated vein that is under the skin that nurses or dialysis technicians can put needles into to take blood out from the access, purify it in the dialysis machine, and run it back into the patient. And of course, all of our experience till now suggests that the best form of vascular access, the gold standard, if you will, in most patients, maybe not in everyone because we want to individualize care, but in most patients, the arteriovenous fistula is the gold standard, because once it really starts working, it lasts for a very long time, and it has a far, far lower rate of infection, particularly as compared with catheters, but also as compared with arteriovenous graft. There are obviously now, since we've got the EndoAVF, two types of arteriovenous fistula creation. On the left is your classical surgically created arteriovenous fistula that I will go into a little bit more detail in over the next few slides. And then on the right, you have this innovation, which is really a fistula without a scar, which is an endovascular fistula that is created, as Neghae will describe to you, through an endovascular approach. And I will say, we often talk about the fact that if you put your hand over a fistula, you feel a thrill. For me, it's actually a huge thrill to be able to feel a thrill in a fistula without a scar. I'm older than the others on the panel. I never really thought that this was going to happen, and I think it's an exciting time because of that. So what happens in a traditional surgical fistula? It's created in the operating room or in an ambulatory surgical center. There are different types of anesthesia that are used depending on the patient and depending on where the access is going to be created. But then after anesthesia, which could be through a block or general anesthesia, or in some cases local, you create an incision, you expose the artery and the vein. And as you can see over here, the vein is dissected out and then really sewn onto the artery. And then you get this high pressure, high flow blood going through the artery, which then dilates, going through the vein, I beg your pardon, which then dilates the vein. And that's what we call as a fistula. And you obviously need often about 3 months or more for this vein to actually dilate out and mature. And as you can see over here, after you create the fistula, the surgical opening is sewn shut. It really heals over the next 2 to 3 weeks. And when you have a surgical fistula created, you are going to have a scar that's going to help to identify where the AVF was created. One point that is important, I think Neghae will speak a little bit more about this. When you create a surgical arteriovenous fistula, you really have the blood flow going up through a single vein, and the dialysis technicians can put needles into that vein. Things can be a little bit different, interesting, but also different when you create an endovascular AVF. But in general, surgical AVFs have a single outflow. The next slide is really where I hand over to Dr. Mawla. Okay, what I think this is where I'm supposed to hand over, I believe, or I'm going to hand over at this point. And I just want to say again, I've sort of laid the groundwork to tell you what a surgical AVF is, and Neghae is going to take the next step forward and tell you about what an endovascular AVF is and about the innovations that we have in the year 2022. So Neghae, over to you.
Thank you so much, Prabir, and thank you, BD and AAKP, for having us So let's get into the endovascular side. I'm going to kind of try to go quickly through this because there's some great questions and I really want to open up the discussion. So the endovascular fistula is a non-surgical fistula. And so it's all done through sheaths, or basically big IVs. And you can kind of see that in the bottom of the upper arm on the picture right there. And so we put one sheath in the artery and we put one sheath into the vein, and that's how we're able to make the connection. So there's two ways to make a WavelinQ, and so there is one artery in the upper arm that splits into the two arteries in the forearm, and so you can use either artery for your endovascular, your WavelinQ fistula creation, and that's really dependent on the operator to decide which way is a better route to take. But it's just a matter of knowing that we've got two options, and you can even use one option and then later on, if we need to, go to a second option and do it on the other side if you can. So that's one of the advantages of the endovascular fistula, in addition to there being no scars. And so the first step is getting access through the vessels. And so you can see the sheaths here. There is one in the vein in the upper arm. There is one in the artery in the upper arm. And then we get our sheaths put in and we put a wire down. And the wire is basically my railroad track. So once my wire is in position and across all the territory I need to, then all of my tools can travel over that wire to get the work done. And so the WavelinQ catheter is brought down into the appropriate zone where the fistula, where the connection is going to be made. And so there is one catheter in the artery, and you can see that there in the diagram. There's another catheter in the vein, and that's basically the active catheter. And what that does is that creates the connection between the artery and the vein. And the reason this works is because you're in the deep vessels and in the deeper location where the artery and vein are already sitting close together. And so, as Prabir mentioned, a surgical fistula is a superficial vein, and the surgeon will take it and move it down to the artery at the deep level and sew it together. But an endovascular fistula is a deep connection between the deep artery and the deep vein, and then the flow comes up to the surface, and we're able to use the same upper arm vein as a surgical fistula. And so when it heals, really the only place that requires healing is where the sheaths went in the upper arm, and you just put a little pressure there, and then usually that does fine over the next day or two, and really letting the connection site kind of establish itself and heal over the next 3 to 4 weeks is kind of the other part of it. But really, in terms of activity, most people are back to normal activity within a week. This diagram is a little confusing, and there's a lot going on here. Let's start in the upper arm and look at the red vessel. That's the artery that is the brachial artery that kind of comes down. And as it splits, and so we're following that, and as it splits, we're making a connection there between the artery and the vein at the deep level. That vein is going to come up a perforating vein. And so that perforating vein, the job of it is what it does is it connects the surface vein to the deep veins. And that's what allows me to make this deep connection without surgery, right? Because remember, as we mentioned before, surgery requires you to take a superficial vessel, a surface vein, and you move it down to the artery at the deep level, and it can be wherever I want to put it because I'm mobilizing it. But here, I require all the vessels to line up on their own naturally. That vein from the deep level needs to come up to the surface so that the connection made at the deep artery and vein flows up to the surface. And sometimes that vein that comes up to the surface will actually split into the two surface veins. There's a cephalic vein in the upper arm, a basilic vein in the upper arm, and sometimes that perforating, actually most of the time, that perforating vein connects to both. And so you get what's called a split outflow. You basically get two fistulas for one. And it becomes very nice from that perspective because it gives you a little more vein to develop. It gives you a little more options in terms of needling and cannulation. So the main differences between a surgical and a non-surgical fistula is obviously the scars are not there. And a surgical fistula is typically a single outflow. So one artery, one vein. Versus a non-surgical fistula can have one artery going into multiple veins. And so most of the flow is actually at the surface veins, which could be one or two, but you might get a little bit of flow at the deep veins as well, because remember, the connection is the deep vein to the artery. And so it is multiple outflow. And I think there can be some advantages to that. There can be some challenges to that as well. So how do you identify the patients? First is you're going to feel for the thrill, but the thrill side, because there's no scar, usually we find the scar to identify where the thrill is going to be the strongest. In an endovascular fistula, the anastomosis, the connection is always below the elbow. And so usually you're going to feel kind of right where it's circled for that thrill, and that's going to be where it's the strongest. It's not as strong as a surgical fistula because it's deeper, the connection level, and the flows are a little bit lower. So you're not going to feel it as strongly as you do a surgical one. But it is definitely there. You just have to know where to look for it. And then you can see here, actually, it is a split outflow just above the circle. You can see one vein going off to the right of the arm, and then a second vein, yep, going off right there to the left. And so this gives you lots of room in terms of where to put your needles. And so again, where can you needle? It just depends on where the vein is that develops. And you know, this becomes a potential challenge, is finding the right vein to mature and develop, but most of the time it develops, you just have to know where to look. And so you can see on the left, they have one needle in the cephalic vein, the red needle with the red line up at the top, upper arm, and they have one needle into the median cubital or the basilic vein, which is, so here is a split outflow. On the right arm, both needles are in a single vessel because this was a single vessel endovascular fistula. And everybody's anatomy is different, so that's something I don't control. They just say, okay, you're going to have one, you're going to have two, this is where we're going to stick, and it's one of those things you just, as it develops, you just kind of work with. How do we decide who's a candidate for an endovascular or a non-surgical fistula creation? All of this is done with vessel mapping or vein mapping, and it's always pretty much done under ultrasound. That gives me the best images and the best sizes to figure out what the surface vessels look like, what the deep vessels look like, and what this bridging vein looks like that connects my surface to the deep. First and foremost, you have to be a candidate for a surgical fistula. If your veins are too small, or if your veins are weak, if your veins are not good enough for a surgical fistula, you can't have a non-surgical fistula. So the upper arm veins are what we look for. So if you're a candidate for a surgical fistula, then we look into the elbow fold to look, and the elbow crease, to really look at that bridging vein to the deep vessels to see if we can do a non-surgical connection instead of a surgical connection. And so here is the territory in the elbow fold that we look for. And if you look at this ultrasound image, you can see the artery right there that splits into the two arteries, and then the vein highlighted in blue that starts kind of at the very top, which connects to the surface vein and works its way all the way down next to the artery. And so if you see that artery and vein sitting right next to each other and everything is big enough, then you can say, all right, this is a potential patient or a potential person that could receive an endovascular fistula. Other things we need to look at in terms of that, but this becomes the primary thing, is looking at this perforating vein or this bridging vein that connects the surface to the deep level. If this is there and if this is big enough, then we can say, all right, let's look at our endovascular options. So who cannot get a surgical or an endovascular fistula? I mean, if you don't have that perforating vein or that bridging vein, then you can't do it. If there's blockages higher up in the arm, in the shoulder, or the chest, then you can't do it. And if the vessels are too small, because everything has to be big enough and there's sizing requirements, then you can't do it. And so all of that's looked at the time of vessel mapping. Every fistula, surgical or not, may require some intervention or some boosting procedure, as I like to call it, to really get the flow going a little bit better. And so this is the same of endovascular fistulas. A lot of times while it's developing or maturing, we go in and do an angioplasty to try to get more flow through the fistula and up to the surface. And then of course, every fistula often requires kind of maintenance tune-ups to keep the flow going in the right direction. So advantages of a non-surgical: one definitely is the cosmetic side of it. You're not seeing a scar. The veins are not as prominent, so it's not as noticeable, which is a huge advantage. Number two is it really gives you more options for where to make that connection. And this is a new kind of, it utilizes the same surface vein for needling at dialysis, but it gives you new options to make a connection. So I can do a connection here down at the deep level, and it doesn't take away from the surgical options. So if that fails, you can move on to a surgical upper arm fistula without any difficulty. And then three, because this is non-surgical, It can be done with very little sedation, depending on how comfortable the operator is. You can do it under regional anesthesia, which is you basically put the arm to sleep, or you can do it just with local anesthesia and a little bit of sedation. So it is much easier to tolerate in terms of patients. All right, I'm going to hand it off to Brandy now.
So dialysis and vascular education, it occurs in many stages of the patient's journey. So patients, most of the time, it'll be in-center home dialysis support team, the managing nephrologist, of course, the creating physicians, vascular surgeons, general surgeons, interventional radiologists, and interventional nephrologists. In the dialysis centers, it's the nurses, technicians, and facility administrators. And access maintenance physicians, which is the vascular surgeons, general surgeons, interventional radiologists, and interventional nephrologists are involved in access care. Dialysis Ready is an ESKD awareness resource. Patients can go to this website, patients and doctors, to learn more about their kidney disease, discover treatment options, and find tips for their vascular access, and find physicians near them. It is also a way for physicians to be identified by dialysis patients and participate in a network of clinicians focused on ESKD. It's coming 2023, a place to share stories about patients and caregivers who are focused on improving care along the ESKD continuum. Patient resources, we have brochures and all kinds of things. I'm one of the clinical educators, and I go into the centers for first cannulations of the endovascular fistula. I help assist the centers on how to identify, offer education on how these differ, and just we have a whole lot of resources to help the patients along their journey. And I think next is Christine's.
My name is Christine Hernandez. I'm a kidney warrior, as we call ourselves. And I'm also a registered nurse. In 2016, I found out that I had a genetic defect that was going to cause my kidneys to fail. And I had asked the doctor, I asked them what options I have for treatment. Like, I started thinking, hey, maybe they could do angioplasty, for my kidneys and it'll work. And he said, no. The only treatments for my kidney disease was either dialysis or transplant. And that started my journey with kidney disease. So, and then when my GFR was around 20, I think that was like 2018, I started doing research because I wanted to be proactive because I didn't want to be more reactive and get like a chest port. I mean, if it's necessary, it's necessary, of course, but if I could have been proactive and look for options, I was going to do that as the patient. So I started doing some homework and started looking up fistula, types of dialysis. Then I started looking up fistula that is least invasive and less risk for infection. And then I came upon the WavelinQ. So I started doing research and reading on WavelinQ because I didn't know anything like that existed, because I was only introduced to two, the fistula, the graft, and then PD. And I wanted to know if there was more options for us. As kidney patients, you lose kind of a sense of control towards the end. So I wanted to have some power in choosing my choice for my fistula if I had that choice, and I actually did. So I took my the information from the WavelinQ. I printed it out. I spoke to my nephrologist about it. So the next appointment, I brought him the paperwork, and it turns out that they actually had a symposium on WavelinQ, and there was a doctor that was had been trained to do them at the hospital. So it went really fast. I went to made the appointment. I met the BD team, and I met my interventional radiologist. He's very involved in my care. And then they mapped me, and it turns out I was good. I had good vessels, so I was able to do it. And the one thing I remember most about when I had my procedure was when I went in to the procedure room and I came out, that the nurse, she went to see my fistula at the creation, and she opened it and she didn't see anything. So she walked out and her eyes were like wide open. And she told the other nurse, hey, didn't she get like a fistula put in today? And she was like, yeah, what happened? I don't see it. So then they both came in, and then the doctor came in at that time too, and he says, you guys look puzzled, and you want to see her fistula, you got to feel it. And they felt it, and they were amazed by feeling the thrill, and just that something was working without seeing any scarring or anything like that. I like the fact that when I cannulate, I could cannulate both sides, and I still have a big area that I haven't even touched yet, that the doctor said if I want to, it's just a little deeper in cannulation technique, but it's really big, so it's grown and matured. So it gives you, to me, longer lifespan of the fistula, because you're not going to the same spot. But like every fistula, I take care of my fistula. I make myself responsible for it. I'm aware of signs and symptoms to look for. I make sure I don't get any infections in it. So it's easy to care for. It clots really fast when you stop bleeding. I say in like 3 to 5 minutes, I'm out after I stop my dialysis. So it's really good in that purpose too. It's good for me and for the technician, because she's trying to get the next patient on, and I'm trying to get out the dialysis center. So it has been a blessing in my life, and I'm happy I did my research, and I want more people to know about this, because I feel like having more options just makes you feel more empowered.
Yeah, Christine, I was, I think your comment about getting control or having control is just a really powerful message. So, I mean, how should patients or people living with kidney disease in the audience, what if they want to get more control over their vascular access and their dialysis, what would you tell them to do?
Well, I would say ask questions, right? Talk to the doctors, be very involved in your care plan. Don't be cared for, but be part of the care plan. So you're part of the team. So a lot of patients don't speak up, but you part of that team. So you have an equal responsibility also to say, hey, I felt this, or this doesn't feel right, or could you check this? And ask questions, because the questions is what's going to make everything successful.
Christine, how long have you had your fistula now?
In September, it'll be three years. 3 years.
Fantastic.
Yeah. And I go in for, like, I call it a tune-up, like once a year. The only reason I go because I want to check it, I'm, like I said, I'm very proactive. So I want this to last up my lifetime if it has to. So I plan on having a long time, and I take care of it.
No, that's absolutely great, that story. And so you got in the early days of the WavelinQ. So there were not a lot of people doing it. It was, it was hard to find people in, almost 3 years ago doing it. So it worked out to your advantage that you had somebody local for you. Good for you.
You're a pioneer. That's so I know that Erin was maybe going to come on with some questions, but Christine, why don't I ask you a question that I think came up initially from the audience, and it's really again to expand upon your thoughts about the EndoAVF. And the question is, do you think that this new fistula is going to result in less chances of having those big fistulae that patients often have with big bumps? So really the question is, tell us more about how you feel about your fistula. Does it look okay? Does it, are you tickled that you don't have the scar? Are you more, are you happier just wearing, things where, sleeveless things, or, having your arms open out to the sun and the air? Go ahead.
I definitely feel I feel like it's a blessing that I've used it. It's going on 3 years in November, but the creation in September, and I just have a little area that's just matured, but no big bumps. I mean, I could show it if you guys want. And the only reason you could tell that it's official is because you could see the site, the insertion sites. I have so many of them throughout my arm. And but other than that, I take care of it. Like after dialysis, and once it's clotted, and I wash it, and then I'll put some like Aquaphor to take care of the skin. And so I have like a whole regimen that I do to take care of my skin outside of dialysis, so that way it could just stay presentable. And I think it is.
Yeah. And
Christine, do you still cannulate?
I do, and so when like my technician that I showed her how to do it really good, and because the WavelinQ also is like it's like a regular vessel, so you have to kind of, when you're going in, like a regular venipuncture, not at the big 45-degree angle yet. It could be like 15 to 20, and you go slide in. And then holding it when you're going in, just like a vein that that will roll around, that it behaves like a regular vessel. So I self-cannulate, and when she's out, I self-cannulate.
So Christine, I mean, linked to that, I mean, the biggest thing about self-cannulation perhaps is that you have control, right? You have to be so invested in your vascular access if you're going to be putting 6 needles in per week. I think that's great, right? That's what we want in the vascular access community. So what's your advice to all of us on how we can get more people to self-cannulate? I mean, you are the absolute exception. I also, particularly because you actually self-cannulate even when you're in an in-center hemodialysis unit. So how do we change this? How do we get more people to do this?
So the dialysis centers are more than willing to show people how to cannulate, self-cannulate. And then, so you could ask your nurse or the technician to tell the nurse that you're interested in learning how to cannulate, and then they'll show you how to cannulate the fistula, because no one's going to take care of your fistula better than you can.
So we'll put that out as a call to action. I mean, it saves time. It gives you're more vested and invested in your access. And as you said, who knows your fistula better than yourself? Erin, any other question? Any questions from the audience? Because and I'm going to say we'd love to get real-time questions in, because that's what makes this really fun. So any questions coming in from the audience in response to what Christina said till now?
Yes, we do. And I wanted to say that you all did a fantastic job on your presentations, and we appreciate you sharing your expertise and your time with us. One question that we did get is, will this access become the new norm?
So that's an important one. Neghae, you've been, let's hear from what the physician's point of view is.
I think it will become a good option for a lot of people, but most people don't have the veins, either that bridging vein or the deep vein or a surface vein, to necessarily do this. So I think yes, you will find lots of providers in the Dallas area. I think there's almost a dozen providers that can do a WavelinQ endovascular fistula between radiologists, nephrologists, and surgeons. But the patient's anatomy is one of those things that we're completely dependent on. So not everybody will get one, but yes, I think it will become a good option for a lot of people.
Yeah. So I have two follow-up questions on that, Neghae. So if you have 100 patients who want to get an arteriovenous fistula, an EndoAVF, how many of them do you think would have the anatomy to be able to get one?
So for me, in my practice, it's about 30 patients or so will get one.
Okay. And the second question linked to that is, do you think that the technology will improve over time so that we may be able to surmount some of the venous and arterial anatomy issues?
It could be. The device is, the WavelinQ device is actually on its 3rd generation device. And so they have taken the technology and looked at the 1st gen and said, okay, how can we make it a little bit better? Looked at 2nd gen and said, okay, what else can we do? So, that's very much dependent on actually industry and the need to want to say, okay, how can we make this better? Because the 1st generation device and the 3rd generation device has dramatically increased how many patients we can do this on versus, how we could before. So definitely an option.
Excellent. There's another question sort of linked to it, and I hope I'm not taking away any questions that you have, Erin, but there's this. So this is, there's the good, and you always have to be aware of are there complications, are there things that can go wrong, and so the question is that as a parent of a 27-year-old CKD stage 5 patient, what are the warning signs that one should perhaps look for after the creation of an EndoAVF? And are there some signs that are maybe different from a standard surgical AVF, and what are some of the complications that could occur?
Most of it is the same as a surgical AVF, actually. And really what you're looking for is bruising and swelling and how bad that might be, and weakness down into the hand, possibly immediately after, really wanting to make sure you're looking at your flow and that the flow down to the hand isn't compromised. But I don't think that's any different for an endovascular fistula than it is for a surgical fistula. I would look at the same complications or the same concerns to have afterwards.
And would most people have to have a second intervention?
Most people, probably about half or so, will require an angioplasty to help get that flow up to kind of speed, to get the flow in flowing fast enough for dialysis, and also to shift it. Because remember, there's flow at the deep level and there's flow at the surface that we want. And sometimes we just need to shift the flow from the deep to the surface. So I would probably say about half the patients need something to help kind of flow diversion techniques.
Yeah. And then finally, the key question, and you may not have enough data on this, do you think that the EndoAVFs are going to last longer than the surgically created AVFs? And
That's a really good question. I don't think yeah.
Go ahead.
I don't think the data is out there yet to say how well they'll last. I think the ones that take do very well. I think from my patients and what I've seen, the aneurysm sizes are smaller, the aneurysm kind of rates are lower. Once they're mature, the interventions and the procedures required seem to be fewer. This is a great question, but I don't think we have all the answers yet.
Okay. And I guess another question, and this would be to Brandy and to Christine, is one of the problems with new technology often is the implementation, right? So it's out there, but is there really the education and the awareness within the community as a whole, including patients? So for Brandy and Christine, I mean, are there ways that, do you think that, are there things that we should be doing as a community to spread the message about these new techniques? More than just
certainly.
Yes, go ahead, Brandy, please.
I certainly think there is, and getting out into the, presenting at national meetings and things like that is really great. But getting in front of the patients in the dialysis center is one of the most important pieces of this. And I do this on a daily basis in my job. Not only am I a caregiver of a patient with a WavelinQ, but I changed my career path because of him. Became a WavelinQ dialysis specialist out of the laboratory community because I felt like it was just such an important aspect of healthcare. It's medical history in the making, and the more patients that we can touch with this or get in front of in the dialysis centers. I mean, just because we presented at a national meeting doesn't mean that a dialysis center like where I am here in Longview, they had never seen one before today. And I was able to get in there and get in front of them and talk to some doctors and talk to some nurse practitioners. And I think getting the word out there on that level in the communities is going to be the most important part of helping this spread, that there are other options available for patients other than surgicals.
And
Yes.
Christine, do you think are there pathways through the patient community that this could happen, or Erin, as an office bearer of AAKP?
Absolutely. So this webinar is being recorded, so we will share this on our webinar. We'll share it on social media. We'll send out an e-blast to our membership. So we will continue to get the word out about this this innovation, and we're happy to share that with patients. We do have a few additional questions that came in from audience members, if you don't mind, that I'd like to have addressed. One question going back to, I believe this was when Christine was talking, one individual is asking what it means to cannulate. If you could possibly share on that, Christine or Dr. Mawla, what cannulate means.
Christine, I'll let you answer this one.
Cannulate is the actual insertion of the needle into the blood vessel. So it's the actual process. When you're getting yourself on dialysis, they put the needle in, so that's called cannulation.
Thank you. Another couple of questions that we received were, how long does this procedure take? And one additional question I wanted to throw out there is, someone in the audience has been a peritoneal dialysis patient for 10 years, and they want to know if they might be able to qualify for this non-surgical access.
Dr. Mawla.
So the procedure itself, probably about 30, 45 minutes. Most of my patients are check-in to check-out time is 3 hours, 3 to 4 hours is usually what it is. So they're there half a day. Peritoneal dialysis patients considering hemodialysis, absolutely. You just have to get screened to see if this is something you're a candidate for.
Thank you. And one additional question, if you don't mind. Let me get back to that now. Let's see. All right, one individual asked, if you tend to bleed when needles are removed at the end of dialysis, will this still be an issue, or is this something that will not happen quite as often?
That may be a different issue with an existing access. Usually that is something kind of where there's a narrowing higher up in the arm that causes the bleeding to happen. That can happen just as well with an endovascular fistula. Generally, I'm seeing it less, but it is something that still is a possibility.
Thank you so much. Dr. Roy-Chaudhury, did you have any additional questions that you wanted to pose to the panelists?
Yeah, so there's one question that I think is a really important one, and I'm going to pose it to maybe to Neghae first, and then to Christine. How long is it going to be before this procedure is available to everybody? And what are the things that AAKP in particular can do? What are the things that AAKP can do in terms of advocacy for this to happen? So in other words, equity in availability of this new procedure. Neghae?
There it's a matter of finding providers that are interested and really pushing for dialysis patients. And I think every major metropolitan city is bringing this program on board in one fashion or another. It may not be community hospitals, it may be in academic and teaching hospitals instead, but most large cities, I think, have an endovascular fistula program on board, and I think it will just continue to grow. As far as the AAKP, Christine, I'll let you answer that one.
Well, like today, what we're doing, we're educating our ambassadors, our community, and letting them know that there's options for them, and then spreading the word on like on social media and stuff like that. So if it doesn't happen provider, like WavelinQ to provider, it could happen patient to patient. So word of mouth, you know. What do you have? I always speak at the dialysis center and let them know what I have. I actually had one person go and get mapped like a week ago because she wanted a chance to have something like this, you know, because she didn't know even it existed. And then maybe also having like little, like the way they have posters of the, you know, the fistula and the PD and the have a WavelinQ picture also, you know, for our doctors, and the patients are going to have to be asking the doctors, you know, because the doctors, if they don't know about it or no provider that does it, they'll do research for that patient, of course, and try to see if they can find somebody.
Right, and going back to Christine's original comments about how she took this into her own hands, I have lots of patients that come to me from hours away. All of my patients are not local to me. There are several patients that have come from 2, 3, 5 hours away just to see if they're a candidate, and sometimes they're not. And but they just like you, they really wanted this. They wanted to know if it was something for them, and they took the effort and they made the drive.
So I'm looking at the time, and we're just past 8 o'clock. So what I want to say at the end, and then I'm going to hand over to you, Erin, for actually, I'm going to change it a little bit. I'd like final comments from all of our panelists. So Christine, why don't you go first? Some final comments for the audience.
You're your best advocate. You have to speak out. If you have questions, ask it. They have to have, you know, if they don't have the answers, they'll get it for you. Just try to stay informed. There's the internet out there. You could see research papers. You could read them. Do your research on the modalities. Know you have options, because you're going to be your best advocate.
Thank you. And you've been a champion clearly for that. Neghae, what are your thoughts?
Christine, I'm going to echo what Christine says. Do your homework, study what's out there, and really push for yourself. No one will take better care of you than yourself. And that's what it's going to boil down to finding your best options. And whether it's a travel or not, you're the one to do it.
Thank you. Brandy, your message.
I have to speak to the care partners. Y'all are warriors too. Yay. I know what it's like to be a care partner, and your best voice is to be the voice of who you're taking care of, and back them up in their advocacy of taking care of themselves. Always support them, be there for them. Whatever they want to do that's best for them, you be sure that you back up their play. Most important. They're the important ones, the patient.
And I guess my final message would be that I am just so impressed by what you've done, Christine, and by what you've done, what both of you are doing. And so my final message is that I think that the best way, without doubt, to advocate for better vascular access is for patients to be really leading the charge to do so. And I can tell you that when you go, if you advocate up on Capitol Hill, to have a patient, a person living with kidney disease there advocating, it just makes it totally different. So, you know, the message out there is that for me is that I think patients need to lead the advocacy for better kidney care, for better vascular access care. And with that, Erin, that's the charge really, Erin, for AAKP. And with that, I really want to thank all of the panelists, Neghae, Brandy, Christine, thank you so much. And Erin, thank you, of course, to AAKP, and also thank you to BD for their sponsorship. And I'm going to hand back to you, Erin.
Thank you so much, Dr. Roy-Chaudhury. You've been a fantastic moderator. I couldn't have done a better job than you. And I appreciate all of our panelists' time, Christine, Brandy, Dr. Mawla. Thank you for answering all of these questions. And it's very obvious that you all are patient-centered and are really advocating for and fighting for what individuals need themselves. And that's truly appreciated and something that we applaud you for. So thank you so much for each of you for being on this webinar. I do have a couple of closing slides. And if anybody has a question that we did not cover in the presentation, you can email us at info@aakp.org, and I'll work with today's speakers to provide a response for you. If you're not already a member of AAKP, we encourage you to join us. We offer free membership to patients and family members, as well as living kidney donors. You can join online or by phone. And in order to receive all the benefits of membership, we ask that you include your email address when signing up. And you will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. You can also select to receive any of our 5 different electronic newsletters and subscribe to our print magazine, AAKP Renal Life. Please also follow us on our blog and social media for all of the latest news and announcements. AAKP is dedicated to helping patients understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients and caregivers. We also offer numerous kidney-friendly recipes with details on the nutritional content and which stage of kidney disease these recipes are good for. You can visit our website at aakp.org and click on the store button at the top of the homepage, where you can download or order materials online. We have a wonderful coronavirus resource section on our website that we keep up to date that I hope you will check out. And please save the dates for our 2022 signature events, which will all be happening virtual. We have our Global Innovation Summit coming up towards the end of May, and we partner with George Washington University School of Medicine and Health Sciences for this 4th annual event. We have our annual Policy Summit on June 30th and our annual National Patient Meeting September 21st through 23rd. You can also you can also visit our on-demand webpage where you can find recordings from our previous educational sessions. And thank you again so much to Dr. Roy-Chaudhury, Dr. Mawla, Brandy Taylor, and Christine Hernandez for their time today. You all did a wonderful job, and thank you so much to BD for sponsoring this AAKP HealthLine Innovator webinar. Thank you all for joining us today. Be informed and stay safe. Thank you.
Thank you all.
Thank you all.
Thank you.